Chapter 37, Disorders of Brain Function. So we know that the brain is highly dependent upon oxygenation. Hypoxia and ischemia are the two most common causes of brain dysfunction due to trauma. Hypoxia causes the depletion of ATP, or results in a power failure, if you will. Aerobic metabolism stops when less ATP is when hypoxia occurs and less ATP is produced. And this causes the cells of the brain to swell up with water. Because of the lack of energy production, anaerobic metabolism begins, and we know that anytime our body is in anaerobic metabolism, we produce lactic acid, and this lactic acid creates further damages to the cell membranes, intracellular structures, and DNA of the brain. So oxygen is needed for power production of energy, and without it, the body runs on anaerobic metabolism, creating increased lactic acid production and cell damage. Other consequences of ischemia include the ability to utilize energy stores, glucose stores, damage to blood vessels, where it can result in vasoconstriction and vasomotor paralysis, and changes in the function of the blood plasma, causing desaturation, more desaturation again, less oxygenation carrying capacity, clotting, and sludging. Another disorder Another disorder that creates havoc or wreaks havoc within the body is increased intracranial pressure. The fact that the skull forms a compartment around the brain, and that compartment is finite, when the intracranial pressure becomes higher than the arterial blood pressure, it creates brain swelling and creates a cutoff of the blood flow to the brain because it's trapped. Think of compartment syndrome when we have a cast on and the fingers swell because of the compression of the cast on the arteries of the arm. It's the same thing happening in the head. As the brain begins to swell, you can either have a vasogenic or a cytotoxic component related to it based on the underlying factors that are happening. So think of vasogenic as it's an extracellular fluid issue, and cytotoxic is an intracellular fluid issue. Other causes of increased intracranial pressure can be due to hydrocephalus, where you're producing too much cerebrospinal fluid, and where you have a tumor of some sort growing in the brain, which reduces the space that the brain has. We're not going to focus a lot on increased intracranial pressure, other than you need to know that it is an emergency and what the signs and symptoms are if the patient is beginning to experience increased intracranial pressure. Seizures are the spontaneous nerve firing of nerves in the brain. They can be caused or provoked by things as simple as electrolyte imbalances, fever, or decreased blood sugar, or some sort of infection. Seizures are a symptom of this spontaneous nerve firing. Now, we also have a disease called epilepsy, where the patient undergoes seizures not as related to infection or any of the other items that we called for before. It just has a faulty wiring, if you will. Seizures in epilepsy can be partial or generalized, where they involve both hemispheres. It can begin in one side and go to the other, but basically in epilepsy you have a faulty wiring that is the cause, where other kinds of seizures are caused by some external agent that's happening to the body, not because of the actual intrinsic wiring being wrong. We're still studying what causes epilepsy. We know more today than we did before. What we do understand is it's very important to be able to describe what is happening during the seizures, and that's one of the roles that the nurse plays, is this reporting mechanism. Is it a seizure of absence, where basically you have disturbances in consciousness, from I faint and I'm totally out, to I'm just not responding to you for periods of a time. We want to be able to describe whether there's loss of muscle tone, or whether there's severe muscle contraction. That tells us where the origins are of the seizure. We want to know if we have both of those things going on. So understanding whether we have a loss of consciousness, what kind of tonic or clonic rhythm of muscle tone we have, and are they continuous, or do they have a start and a stop? It's very important for us as nurses, and if they end up in the hospital, to be able to describe these things. How long did it take? Was there loss of bowel and bladder function after the seizure or during the seizure? We really don't know. Sometimes the cause is idiopathic, and these kinds of descriptions help us, or help the neurologist, doctor, figure out what's going on. We usually like to try and figure out if there are any precipitating factors. Does it always occur at a certain time? Does it occur because of lack of sleep or emotional stress? Are there any auras or signals at the beginning of the seizure? A pungent smell, nausea or indigestion, an unusual taste, or some sort of visual disturbance like a flashing light. Treatment of epilepsy is usually trying to reduce the frequency of seizures or to prevent their occurrence altogether. Patients who experience seizures cannot drive for up to a year after they've been put into treatment so that they can be safe on the road. Doctors are required to report people with seizures to the DMV to take their license away. Generally, we begin with some sort of a drug therapy. Commonly prescribed drugs for tonic-clonic seizures are Dilantin, phenobarb, Klonopin, and sometimes valproic acid or Depakine. There are new treatments available. Sometimes we do surgery trying to figure out where the underlying problem is. If it's happening because of a tumor, we would remove the tumor. But they also have like little defibrillators that they actually, or it's like a defibrillator that they actually implant into the brain of epileptic patients now to try and disrupt or regulate that disruption in the electrical activity. Diagnostically, we do EEGs, kind of like an EKG, but it monitors the waves of the brain. We would definitely get a CT scan or an MRI just to see if there were any abnormalities in the internal structures. And we would want to do some basic blood chemistry work in terms of a serum glucose, calcium studies, to make sure that there's nothing wrong with the electrolytes. And also sometimes we would do a lumbar puncture to see that we didn't have any infections in the cerebrospinal fluid that were causing the seizures. So our role first is to rule out any external factors that may be causing the seizures, and then once we've done that, we would work on regulating the neurological signals through medication. Alzheimer's disease is a disease of the elderly. We tend to think of this as a disease that affects people over the age of 65 and generally over the age of 85. It is a primary progressive dementia, and the prognosis is poor. We don't have a cure for Alzheimer's at this point in time. We basically try and manage the disease process. We know that there are two types of Alzheimer's disease, familial and sporadic. We can look and find genes that directly cause the disease, but we can only do that upon death. We know that we don't know how the disease actually works, but we know that there are 4 factors that contribute. We know there's a neurochemical factor, such as some sort of a deficiency in neurotransmitters, whether that be acetylcholine, somatostatin, norepinephrine, or substance P. We know it can be due to some slow-growing central nervous system virus. We know it can happen related to trauma and repetitive trauma, and we know that genetics are a piece of it. What we see upon autopsy in the brain tissue of Alzheimer's patients are 3 distinguishing features. We see some neurofiber tangles that get formed out of fibrous proteins in the neurons. We see beta amyloid plaques, which are these thick deposits of protein-like substances. And we see granulovascular degeneration of the neurons of the brain. We know that the plaques can cause the, this is a MRI of, this is a CT scan of a patient with Alzheimer's. Clearly the one on the right is the Alzheimer's patient, where you see a basic dulling of the neuro ability to transmit in the brain. We know that the stages of Alzheimer's happen in a pretty routine flow. At first, there is short-term memory loss, not the short-term memory loss that that comes with age, but significant short-term memory loss that causes a disruption in the patient's ability to function. In the second stage of Alzheimer's, this is what we call the confusional stage. There's a significant amount of disorientation, sundowning syndrome at night, impaired hygiene and language use, not able to find the right word, and higher level cognitive function for decision making and insight is deteriorating. Last but not least, in the third stage, the brain has primarily resulted in the inability, the plaques in the brain have resulted in the inability to recognize family and friends, and the inability to take care of day-to-day activities of daily living. We treat Alzheimer's. We know that there's no cure. There's a lot of studies going on now to try and figure out how to slow the process down. We give drug therapy such as cholinesterase inhibitors such as Aricept, Razidine, to prevent that breakdown of acetylcholine, so that we can begin to have that chemical messenger in the brain that's very important to memory and other thinking skills. We will also give Namenda, which is a low to moderate affinity aspartate receptor antagonist, which basically works by regulating the activity of glutamate, which is one of the brain's chemicals involved in the processing, storing, and retrieval of information. There are some clinical trials underway for treatment of Alzheimer's disease, including vaccines to stimulate the immune system, to be able to attack those beta amyloid plaques. But again, we're really looking for other cures. Some of the tests that we do to lead us to believe that somebody has Alzheimer's, because remember, we can't do an autopsy and find these plaques later on, but we can do a PET scan, which is what that picture was before, that measures the metabolic activity of the cerebral cortex and helps us confirm early diagnosis. In a CT scan, we may see significant brain atrophy that is more than what occurs with normal aging. Doing an MRI will help us know that we can rule out any other intracranial lesions as the source of dementia. An EEG to look at the brain's electrical activity. Again, we're ruling things out. The CSF, cerebral spinal fluid assessment to make sure that we don't have some sort of a bacterial infection. We may do cerebral blood flow studies to see if we have abnormal blood flow to the brain. And we're looking at potential biomarkers to see if we can slow that. Please take the time this week to watch the basic YouTube videos that are suggested. Those will be important for the disease processes that we are currently studying. That would be MS, spinal cord injury, Parkinson's disease, CVAs versus TIAs, ischemic stroke, hemorrhagic stroke, and traumatic brain injury, intracranial